We are live in 5, 4, 3, 2, 1.
So, good evening, everybody, and welcome to this another episode of Wednesday Musing. And today we are going to discuss a very important topic: how to deal with a difficult patient. Now, difficult patient, we have a variety of them, but we are going to focus on very select topics today, which Dr. Borate sir will elaborate on. To initiate the proceedings, I'll invite Dr. Tarang, our convener today, and over to you, Tarang.
Yeah, thank you everybody and welcome everybody. Like Ashok Shyam sir mentioned that difficult patient is an umbrella term which can encompass a lot of kind of patients which we have discussed previously. We have discussed on cyberchondria and how to handle informed patient or an internet friendly patient. And then we have also discussed on how to handle complications in medicine. So today we are going to discuss on some other kind of patients who act difficult. And along with that, we'll be discussing what causes those patients to behave like that and what are the suggestions we can offer and how to deal with them. So Borate sir, to start with you directly, what are the kind of patients we are going to discuss today?
Yeah, this is a term that I would like to use for patients who apparently are difficult to handle in terms of how they react with their medical attendant and with their illness itself. So quite often, the reason why they are so perceived as difficult is because they are little more emotional than the normal patient. So the underlying cause may be that they're frightened, they're frustrated, they're afraid, they feel something that they're being threatened, their existence is in danger. And so they tend to react in ways that we do not expect from somebody who is coming to us for treatment. So, as somebody said, that when people behave badly, we must understand that it is a cry for help at times. It is because the person is asking something, the person is unable to articulate what is the problem, and he tends to articulate by behaving badly. So we must be empathetic or empathic to these patients, and we must be we must project our care and concern for them. That is very very important. So one type of difficult patient could be what we would call as an angry patient, somebody who is kind of angry, and he is expressing his anger when he is talking to us. So the anger is maybe the underlying factor may be that he's angry because he feels that whatever he has got is going to end up in his losing his job, and then he's going to lose his pay, he's going to lose his physical agility and something, he's going to become disabled. So whatever self-image he has, it is being threatened. So he reacts by being angry. And so as a physician, we must allow him to express his anger and not tell him to tell him off, or criticize him for whatever he's doing. We by telling him, by allowing him to talk, or by allowing him to express his frustration and anger, we are in a way acknowledging that there is something wrong with him. But we are willing to to allow him to give him time to come to the point or let us know what is the underlying problem. And we must also give the impression that we are listening to him, but we are not judging him. We are not showing him that his anger is disturbing us. We don't like his anger. We don't like his attitude. We keep him, we don't express our judgment, or we don't let our behavior, our gestures, our expressions to give the feeling that we are unhappy with whatever he is happening. This is important because the moment the patient or the person who is angry realizes that the person whom he's talking to is supportive, he's not getting upset, then he feels vindicated and his anger tends to subside. And we should help the process. Once the patient's anger is controlled, then it is much easier to deal with whatever problems that the patient has in terms of either his illness itself or in the problems that he has faced in the process of coming to us and in the process of his being treated. Uh, because he is probably angry because he has had to wait for a long time to see a doctor. He may be angry because he feels that he is unfairly asked to do a lot of investigations which he feels is unnecessary. He may feel that, that uh, the whole attitude of the people who are around is not uh, proper and not polite or not respectful, but more authoritarian and more uncaring. Whatever it is, there may be many reasons. So we have to separate the anger. We have to get rid of the anger before we, and quite often, if we do this well, then it stops being a problem and the patient stops being a problem. Another patient that we all see is somebody who is non-compliant, which means that he doesn't follow what we have told him to do. He doesn't take the medicines that we have told him. He doesn't do the exercises that we have told him. And if you have told him not to put weight on the leg, he doesn't listen to it. And when we discover it, when he comes to us for follow-up, we are very unhappy with this patient because we are kind of at a loss to find out why this guy is non-compliant. Now, I must quote a study of such patients that was done, and they found that 27% of these patients could not actually afford the treatment that was suggested. And we just didn't realize it. So when they were asked, they said, look, I wanted to take the medicines, but I didn't have the money and I couldn't get the money. And this is something that we never imagined because we always think that every patient will not have this problem. We just assume it. Then they found that 39% were not willing to take the treatment because they felt that the treatment was not proper. So they felt that whatever the doctor had decided that they should take was not what they felt they should take. And they couldn't say anything in front of the doctor. They just kept quiet. But because they felt that way, they didn't take the treatment. Then they found that, 32% found the instructions too difficult to follow. And then so they didn't follow them. Now, this is a very, very common thing that we as doctors or caregivers or our assistants are too much in a hurry and we tend to give instructions very rapidly. And sometimes we just say that in case you forget, they're all written down here so you can read them and follow them. But in our hurry, we don't realize that the patient has not followed them and the patient is confused and angry. So one mechanism that we always use, and many doctors use it very well, is to ask the patient to repeat what instructions he has, what he has understood. And if he says, I haven't understood, then one has to tell him that, okay, you just wait and, read it first and then see me again. And, somebody will explain to you and so on. So this is a major cause why people don't follow instructions. And there is a certain percentage, almost 20%, patients were offended by whatever treatment they were told because of their own personal beliefs. Now, those beliefs could be that, they felt that, all drugs have side effects and, these drugs may harm them. So they didn't want to take the drug because they were not convinced that it was necessary. Then there could be some people who had some religious reasons. Some people may have had some uh, reasons which um, were not perhaps scientifically tenable, but they were their beliefs, and that's why they decided not to take it. So when we come across a non-compliant patient, instead of getting angry and irritated or exasperated with the patient, we should reflect and realize that is this something that we should be finding out about the affordability, about the know, doubts that the patient has, which are inhibiting him from taking treatment, or whether needs a more detailed explanation and so on. So these are things which will lead to a large number of non-compliant patients becoming compliant. So our effort should be to treat non-compliance as a challenge rather than as a obstacle. We should say, okay, I can deal with it. I'll find a way of, I'll find something, I'll find how I can make him compliant. And one thing that has been tried and found very uh, useful is after you explain something to the patient, some form of treatment, if you ask him, how will this work for you? Do you think you can manage this? Do you think this is okay with you? That is what may evoke the kind of response that will allow us to take care of the problems that I just outlined. So we must not say, here is what I think you should have, this is what you should do. And have you understood what I've said? Instead of which, if we just say, I've explained to you what needs to be done, what you have to do, and this you have to do for so much time and then come back to me. Do you think this can work? Or do you have any more questions? Or do you have any doubts? Other than just dismissing the patient by saying, okay, here's your treatment and see you later. So, uh, one other problem that has been found lately in even in Western societies, it is much more prevalent in our country, is that our patients are illiterate in terms of health. They don't have any education. So imagine a patient who is like not passed out of high school. So he probably cannot even read what we have written. He cannot even follow what we are telling him. And so with such a person, we have to be more patient. You have to use language that he can understand. And we have to ask them to repeat back in the way that they have followed and tell it to them in terms which they can understand, you know. Because when, for example, we just say somebody, "Ya गोळ्या 3 वेळा घ्यायच्या," or take this tablet 3 times a day. Now, he doesn't understand, but if we tell him, what I mean is that you got to take this tablet once when you've had something in the morning. Then you take it again when you have had something to eat in the afternoon. You take one when you had your meal in the night. Then the same 3 times, has a relationship with something that he can understand. But 3 times a day, we just assume that because we understand that 3 times a day means that the frequency of it should be 8 hours. We just assume that patient knows all this. So we have to be a little more sensitive to what is known as limited or poor health literacy. Again, it needs to be emphasized that we should respect people who are illiterate because it's not their fault, it's just that they have they they are in front of you and they have this problem that they are illiterate. Not something that they can it's happened because they it just happened because they were not as fortunate as some others who could afford to be educated. So we should never show our anger, disrespect, irritation with people who have problems which are not necessarily because of their own making. Then the next type of patient that we often get irritated is the one who has many complaints. So he comes and sits down and he says, "How are you feeling?" And he says, "Oh my God, I got lots of problems." And this kind of patient, when we see on the list, before even the patient comes to us, we kind of, exasperated. We would like to see all patients come in with a single problem, like I got a pain in one joint, and then we come give them a solution, and he says fine and goes away. So there's no hassle, there's no problems on either side, the patient as well as the doctor. But to our amazement and sometimes to our irritation, almost all the patients that we see have more than one problem in their own opinion or in their own mind. So we need to get back to being diplomatic and say, what is the most important thing that is a problem today? What seems to be the most major problem that you have? And then focus on that and then um, later on deal with the other problems or tell the patient that, okay, let's first get rid of this problem, but the other problem that you have, we will talk about it when you come back again because I feel that it will probably not be as serious as you think today. And by the time you come for the next, now there is a increasing number of patients who have become cynical about doctors. They generally don't like doctors. And a lot of this is because of the media and the way the media has been projecting the medical profession as somebody that is making money out of the misery of others, somebody who is not to be trusted, somebody who is mm, out to, cheat us or, so on. Now, all these impressions are created because of what they read about doctors and somehow mm, putting out information in great detail about some problems that may have occurred with some patients with doctors. Now, this media problem is exacerbated nowadays by social media because on social media, it's such a subjective thing that anybody who's been to a doctor and has had a bad experience will be extremely vocal and write about it in great detail. And since a large number of people seem to be coming back from medical treatment or medical advice being unhappy, it kind of gets taken up by others and says, yes, yes, I also agree with you and so on. So this is a problem that we have to reflect upon, and majority of the doctors have to say that we need to behave better if we want to dispel this notion and reduce this negative bias that we are seeing, which is affecting, in a way, it's become like a vicious circle. So we need to reorient ourselves and commit to being more, less aggressive and, combative with when we deal with our patients. There are two other types of problems that I need to mention here, which are also very, very common in terms of today than they were, say, 20 years ago, and that is patients with addictions. Because patients who are addicted to painkillers, patients who are addicted to narcotics are going to not get better, and they are going to go to various doctors with the intention of getting some medicines prescribed for themselves. And the moment you, as a doctor who have sufficient experience and pick out that this guy really has not really got a real problem, but he needs medication, and that's why he's come to me. And he is going to go to another doctor after some time, and he feels that I'm not going to give him those medications. So these patients with addiction keep going around to doctors, and they are sometimes difficult. And there is uh, there is some ways in which we can handle this, but uh, this is one type of patient that I have myself seen, not very often, but it's getting more common. The other patient is patient who has got a residual disability, but the disability is far less than what he wants to be compensated for. And he has realized that unless he kind of overplays his disability and keeps insisting that he's not all right, or not all right to the extent that his medical attendants feel, so he is a problem. He is not satisfied. He keeps going to the doctor saying, I'm not getting well and I don't want to go back to work and so on. So here we need to be honest and straightforward and tell these patients, look, I'm here to help you, but I can only do it by being honest. And I'm committed to telling the truth about what I believe is wrong with you and so on. Now, patients may not like what you're saying, but if you are outright honest and straightforward and also firm in what is your opinion, they will respect you, and they may not like what you're saying, but it will put an end to whatever expectations they have in terms of influencing you. So I found that most of the times I used to use the tactic of telling a patient who told me that I'm not feeling well, or I'm not feeling better. I would tell him, okay, extend your leave. Now, a point would come when he realized that he would be going into leave without pay, at which point he would say, no, 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 I need to go back to work. So I used to tell him that you cannot go back to work unless you're fully fit. So, in my opinion, you're fully fit. But if you feel you're not fully fit, then don't go back to work. So at which point he would say, no, no, give me some light duty. I said, no, that concept doesn't exist in companies. Either you're fit to go back to whatever you're doing, or you're not fit. If you're not fit, take more leave. So that point he would say, okay, now I'm fit. Now I'm feeling okay. I want to go back. So there are many ways in which you can overcome these problems, and most orthopedic surgeons with experience learn to deal with this tactfully. Um, the other thing is that we must be humble. We must be willing to say we're sorry if we have made a patient wait for a long time because we got involved or busy with something, and sometimes because we just didn't realize how much time we had spent with some other patient. So instead of saying that, I'm so busy and, all that, we must say that, look, I'm sorry. I'm sorry to keep you waiting. It just happened. I didn't realize. These are things, which will make uh, patients be less difficult with you. Because the moment we react to patients with anger and annoyance, we incite them to also react in the same way. So you should ask yourself, why is it that this patient annoys me? And you will find that quite often, once you tell yourself that no, I'm not going to be annoyed, then you will discover some things about your own self. And so when you are faced with a difficult patient, next time, always be mindful, reflect on, take a pause, take a breath, and do your best. Don't put your worst foot forward.
Right.
I also want to point out some things, but yeah, Tarang, you want to say
Yeah.
something?
Yeah. So before we proceed ahead, I thought I should just point out or head out the types of difficult patients which you mentioned in detail. So to start with, it one would be the angry patient, then the non-compliant ones, then with the multiple complaints, and then there are patient based on the media perceptions made by the media, and then patients with addictions which have come to arise in the last 1 or 2 decades, like you mentioned, and then patients who are looking for compensation in their work. So these were the headings of the kind of difficult patients which we face in our general day-to-day practice. So now, what conditions give rise to such patients, and your suggestions on how to deal with it? Your further more elaborate suggestions on how to deal with it, sir.
Yes, I would just like to mention some of the patients that I have found becoming difficult as patients. Um, One group that I have found is patients who had complex trauma. We as doctors tend to see patients in terms of, okay, like here's this guy who's got a supracondylar, here's this child who's got a supracondylar fracture. Okay. And we tend to think of supracondylar fractures in a certain context. But if we see like 10 patients with supracondylar fracture, we need to understand that some of them are already having a complex type of injury. They have potentially got something that will lead to VIC. They have something that is like a nerve or a injury, and it is not fully blown, but it is there. And these are the patients where we tend to think that okay, I can take care of it, and we tend to uh, emphasize the potential problems that the patient may have and the potential limitations of making a full recovery. And that's where we convert patients or their parents because of the uh, you know mm, difference or the gap between how we project the outcome or the natural history of what is going to happen and what actually happens. Little more severe or little more than what we have kind of laid out to the patient. And this happens in complex traumas, and especially it happens with unusual traumas, rare traumas. Now I have found that patient who has a child with an injury to the elbow, where only there is a vertical shear and a small sleeve of the condyle that seems to have separated, and the patient has an unstable elbow. It looks very innocuous, but it's a very severe injury and it will have lots of problems and a longer period of, uh, uh, you know, convalescence and maybe not the kind of output that the parents tend to have imagined. So, as one gets more and more experienced And as a young surgeon, you want to reassure the patients. You want to make them feel that you're going to make whatever problems they have all right. And in that enthusiasm, we sometimes create this gap between what we get them to expect out of the way we communicate and what actually happens. So this is what I mean by the complex trauma patient. Uh, we tend to make emphasize the problems of complex traumas because in our mm, opinion, we are not able to kind of see that difference unless we ourselves treat a certain number of cases. You see, when you treat like 25, 30 patients of supracondylar fractures under your own supervision, then you can make those differences. Now, when you were a student and a resident, if you were diligent and if you were able to understand all this, you will learn it much earlier. But a lot of people in the beginning of their practice have this problem of under emphasizing the potential problems and outcomes of complex trauma. Complex polytrauma becomes even more difficult because even the patients and the relatives understand the potentially long-term problems that complex polytrauma may lead to. But sometimes, when we tend to treat these polytrauma patients successfully and pretty well, and everything is, we've done a very good job out of a very difficult situation. We ourselves tend to start believing that, because we have, done such a good job, everything else is also going to be better just because of the relatively good outcomes we have been able to achieve with our interventions. This is what I meant by complex polytrauma also being under played in terms of or too much of positive feedback to the patient, and then there is this disconnect between what happens actually and what the patient has started to believe based on the way his doctor has communicated. Failed back, we all know patients who have undergone more than one surgery, and then they go to the third surgeon, and the third surgeon kind of evaluates and says, no, I know what is wrong, and I know that if this is done, this is going to be all right. And again, the enthusiasm sometimes leads to a gap between the expectations created and the actually what is going to happen. Again, I have seen this happen with old untreated congenital deformities as well, where in our eagerness to treat them and the knowledge that we have the expertise to treat them, we sometimes fail to adequately convey the limitations that even the best outcomes will lead to. The same problem when we are treating complications, because when complications have occurred, we tend to sometimes underplay or underemphasize the potential permanent disabilities that we may be looking at, and also the um, time taken for the improvement that the patient should expect. So these are all things which we gradually, as we learn, we tend to be more and more, the gap tends to narrow. But in that interim period and with some doctors, this problem does occur. Just given a few examples. I mean, there could be any number. One could keep adding to this list. And each one of us would, if we kind of recall back, uh, remember a few patients where the patient did not improve to the extent that we expected and did not improve as fast as we expected. But we also remember we'll especially remember it if the ultimate outcome was good, and we will remember it if we lost the patient went to some other doctor and so on. So these are some of my some things that I believe uh, lead to a, uh problem in the relationship between the doctor and the patient, and the patient, because he becomes resentful and combative and so on uh, during the course of his treatment, and therefore gets perceived by the treating doctor as a. Now I'm just going to tell some things which are very important in my opinion, but I don't know how they will be perceived by mm, younger doctors or my colleagues. But one thing that I would strongly advise all doctors, no matter how long they have been in practice, but if they have a a certain number of problems with patients, and uh, they are, they will be able to reflect and judge for themselves whether they are uh, good with patients or they tend to get angry and they have difficulties in communicating with patients. So even the American Academy tells that doctors should take courses in communication skills even when they are in practice. Just like you want to every year go to conferences because you want to learn new things, you want to relearn whatever you think you should relearn, and so on. You must also be willing to take simple communication skills courses, because you already know what they will tell you, but going through that experience will help you to improve yourself. You will learn new and exciting ways to connect with patients. You will find out that as a result of the impact of whatever you have learned, you will feel your outpatients more interesting and less of a drudgery. So most doctors have reported that when they underwent these courses, that led to them becoming more positive, and it generally, the perception about them also improved from the patients as well as their staff. So don't be ashamed or don't think that it is unnecessary or something that you don't need to do. Don't be afraid to take a communication skills course as a part of your continuing education. The other problem is that we have to accept that not all of us are very nice and very pleasant people. Many of us, uh, you know, empathy doesn't come easily to us. We are very, very unwilling to suffer fools, as they say. So many of us who have this problem need to undergo courses that will teach us, techniques that um, make us better communicators, and make us understand and internalize the importance of empathy. And because we need to separate the patient, uh, and the idea that the patient is difficult, and start believing that the situation that the patient is in, or the situation that we and the patient find ourselves in, is what is difficult rather than the patient. So a patient who has a residual complication and a residual stiffness and has come to a point where we know that this is going to remain, and it's going to take a certain amount of time and a certain determination from the point of the patient, which this particular patient seems to not possess. That's where we are at that situation. It's a situation that we are dealing with a patient who has a problem, and we need to be patient and convey to him that this is a problem that will take longer time than what he expects to recover, and perhaps it requires more, you know, attention from him and so on. So we need to retrain ourselves or find out if there's something that we need to change in the way we are as individuals. One other problem, which I know is a very big problem in India, but which is extremely difficult for doctors to deal with, is that in India, even mostly successful doctors tend to see too many patients. You know, I mean, if you can, with a reasonably uh, good attention and a very nice frame of mind, can manage to say 30 patients in a day, and you are constantly seeing 10 to 15 patients more than what could be expected to be fit in the time that you have in that day, you are going to have more problems with your patient. You are going to become more difficult as a doctor, and your number of patients that you perceive as difficult is going to increase. Now, there are various arguments here why doctors are seeing more patients. Um, there is also the perception that somebody who is more busy than what he should be is perceived as successful by patients, and so on. So there are many issues here, but by and large, you will be a better doctor, a nicer doctor, and um, a more positive doctor, and a happier doctor if you are able to restrict the number of patients you see to the number that you can deal with without getting irritated and unhappy. And you will and you should spend more time with patients that you see and more time in between patients. So everything is suddenly reduced to a level where it's a win-win for everybody. We must realize that satisfied patients are always more compliant. Um, Doctors who are in a good frame of mind are always kinder to the staff. Patients are kinder to the staff. And you will discover in the long run that you will get sued less often if you tend to follow this advice that has been given. And this has been actually researched upon as well. And lastly, we sometimes tend to be very harsh on ourselves. We all make mistakes. We all commit errors of judgment. We find it very difficult to accept that we are not as good as we think we are sometimes. So you have to forgive. You have to forgive yourself. You have to say, okay, I'm just what I am. Yes, in this particular patient, my judgment was wrong. I should have been more aware of the potential problems and discuss them more than what I did. So it is very human to understand that we are all human, we all make mistakes, and the process of becoming better, the process of learning, and the process of learning from our mistakes never really ends. And we should be more, uh, willing to accept the fact that we are not gods, we are not perfect, but we are trying to get better and better. And it is a process, and our patients are unhappy. You will be surprised that most of your patients will not be unhappy if they perceive and communicate and connect with their doctor as human beings. Most of the patients that I have treated and whom I felt that I could have done better have never ever even uh, believed that. They always said that you did your best, and if something hasn't been as good as it should be, then we are okay with it. So this thing that we have, that because we think that we are perfect, we are less uh, willing to accept our mistakes, and because we don't want to accept that we did not as good as we thought we would in a given case, we tend to be angry, and patients don't like that. Patients get confused. Patients are human beings. They're willing to live with less than perfect results, because this whole idea of a perfect result is in our minds. It is not in the patient's mind. The patient says, okay, my fracture is healed, but I still have a little less movement. For them, it is not the kind of mm, you know less than good result that you are thinking. For them, it's a perfectly okay situation. They might be willing to live with it. Most of the times, that's what is the reality. So we should realize this and be more forgive, uh, forgiving of ourselves. So that's all I have to say.
Yes. Yeah. So
Tarang.
just to the conditions which turn a normal patient into a difficult one, just to mention a few in orthopedics especially, are the complex trauma and polytrauma patients, and patients with uh, older congenital deformities, and failed patients with failed back syndromes, and the patients who are undergoing multiple surgeries when we are treating their complications. And excellent to the point solutions and suggestions which you mentioned, that one can always do an communication skills workshop by the American Association of Orthopedics, and you have to maintain a healthy volume, like you mentioned, seeing more than 30-40 patients a day, and not giving enough time to every patient will end up making you cranky as well. And yes, very rightly said, you have to be gentle with yourself, because tour is human, and you have to set our standards, and be gentle with yourself. So, sir, a question now, which you mentioned about the American Association of Orthopedics communication skills workshop. uh, where do these workshops take place, online, and how do you suggest to approach these guys?
No. There are communication skills workshops that are available online. Not always, not necessarily recommended or done by the American Association.
Right.
The thing is that we tend to use these less frequently in our professional conferences. Now, for example, if we have these so-called pre-conference workshops, have you seen in our regional or national conferences a workshop on communication skills? No, which means that we need to think of this. We need to understand that this workshop should be a part of every year meeting, because we have young doctors every year. We have doctors who are in practice for a few years and who would be would love to have attend a workshop on skills, communication skills. Just tend to think that it will not be perceived as useful. And we can use those workshops to bring about experiences from senior colleagues also to make them interesting. Like I just told you that, this gap between the expectations we create in our patient's mind and the actual outcome is probably the fundamental cause in many times in the difficulties that we get with the patient. So these will be, communication skills workshops will can be quite interesting. Apart from teaching you or re-educating you of the skills, to actually have case scenarios, and difficulties that are discussed by professional colleagues, and also scenarios with multiple choices where the audience is asked to uh, choose between two or three or four options, and then to be realizing that the option that they chose would not is not the best, perhaps. So we should be doing them more in our country. I'm sure that
Yes.
Dr. Ashok will be more effective in conveying this to.
Conveying this message to the bodies
Yeah,
conducting.
but if your Solapur Orthopedic Association has an annual meeting,
Yeah,
uh, you could.
definitely, I would pitch in for such workshops.
So
Problem is
let's
not
hear
this.
what Ashok has to say about having this as a pre-conference workshop.
No, the problem is not this about the concept of having it. Problem is getting good speakers on it. Speakers who will be balanced in putting up things as they are, not biased in. So we need the right educators. The problem is
Yes.
not whether education is needed or not, but finding the right educators is, in my view, a difficult task.
Yeah.
Yes.
Probably,
See, I'll tell you, Ashok, this is another area which we need to work on as professionals, because the tools of the course we know, but we cannot get people who are only going to talk about those skills, because everybody knows what they are going to talk about. What we need to have is more group discussions with actual problems, and then the moderator or who uh, tries to make the whole group or the various groups understand what they need to take away from this problem that was discussed. So people who are like spent few years in practice or even more experienced people would be interested in this kind of mechanism, rather than somebody just coming and giving them a presentation about the standard uh, you know things that are expected in a communication skills workshop. So that's not what the audience would be interested.
yeah. So,
So
sir, suggesting that we have a case-based discussion on difficult patients.
no, so you would, I mean, somebody like you would say communication skills, like we have this AO basic, then we have the AO advanced, and then the AO review course, because somebody who has done both the basic and the advanced is not interested in going back to that course, but he would like to spend some time discussing difficult problems with an AO experience, instructors. So that is what I mean. I mean that, we could have three modules, and we could say that the basic module is to be done online. It need not be a part of this thing. And everybody who wants to attend the interesting one, that is the advanced one, which I'm referring to, would be only to those who have done the basic one mm, online, and that's the kind of audience we want. And the advanced one is again designed for an audience that has spent, say, more than 10 years in practice, and we need not put any impositions on them about having attended the first two types. We just assume that they are senior enough to be interested only in that aspect that we have reserved for as the syllabus for that particular type of. I mean, this is just what I'm thinking. I'm sure that Ashok knows other people and he himself may have more ideas which could all be kind of put together. I mean, the workshop that the POS is having about instruments and, basic surgical skills and teaching them all these things. At least I know of at least two courses that the BOS is doing, which have come out of the brains of the uh, people who are running the association. See. And they are unique courses that are run by BOS and nobody else yet is doing them. Am I not right, Ashok?
Yeah, that's right, sir.
I mean, two that I know of is one is about the social media and communities, internet focused technology course, yes. And the other one is about instruments and that those kind of courses where so those are specialized courses which I would love to attend now, even if I'm not going to make any use of those skills. They're so interesting, and the way they're designed is so good. And they weren't there 10 years ago. So it speaks highly of the interest that the people who are involved actively in the association are taking in these things and the seriousness with which they're applying themselves. So kudos to Bombay Orthopedic Society. I like to think of myself as part of the Bombay Orthopedic Society because I trained there. So.
Right.
Yes, sir. So I think we wind up here today. Excellently discussed and very precisely spoken about such a vague topic, and very precise solutions as well. Having good communication skills, maintaining a healthy volume, not going over the board with the number of patients you see every day, and obviously setting practical goals and being gentle with yourself in your practice.
See, I would just like to add one thing before we end, is that, when you are running an outpatient, many of the doctors in India don't seem to understand that apart from the time that they actually spend with the patient is only 25% of the time that the patient spends in the clinic. The remaining 75% of the time he spends in different areas. Like he spends some time getting his x-rays taken. He spends some time getting his plaster removed. He spends some time getting his dressing done. He spends some time with the reception. He spends some time with the payment. He spends some time the doctor who is explaining the advice to him and so on. Now, all these areas should not be, boring. They should not be inhospitable. They should work efficiently. They should all behave nicely. They should all be positive and cheerful. Many of us really, work at it, and make that experience nice. Every part of that experience, even if all the human beings involved in this were to be nicer, that everybody, the receptionist smiles at the patient and says, "How are you today?" And it's nice to see you, or something, and it's going to take a little bit of time. So would you like to have something to drink? There are so many things that should be a part of the experience of spending 1.5 hours. And not that just 10 minutes. I mean, however nice the doctor is in those 10 minutes of that whole 1.5 hour experience, the patient is still going to go home unhappy if the rest of the experience has been not as good as it can be. And if you really analyze all this carefully, it just means that you need to train your team better. You need to have a better team. You need to have a better environment. You need to think and apply your mind as if you were the patient. And if you were going to have all this, how would you perceive it uh, uh, better? What you can do. So, if you put yourself at the other end of the other side of the table, you will design and do all these things. So, I think that a lot of scope is there for this because I have been a patient not only with orthopedic surgeons myself, but I have been a patient with so many other specialties, so many hospitals, and I every time come away fairly dissatisfied. Sometimes I have had extremely good experiences with the staff and with the people who are running the show, but they are like, it has happened only 5% of the times that I've gone somewhere to, as a patient to somebody's out. So I think that we need to, there's a lot of scope to do things better.
Right. So, like most of the time is not just spent in the OPD. When a practitioner ends up spending on making his OPD look all fancy. So he
Yeah.
needs to take care of the other equipments and facilities in his hospital as well, because that is where the most of the time of the patient is spent. Right. So, okay, it was a wonderful meet, and it's time for us to tune out. If Ashok Shyam sir permits us.
Yeah, I mean, this is a topic which is very, very again subjective to each one of us on how we deal. But collectively, like Sir said, if we share our experiences and learn from each other, we'll be better tuned into dealing with it. There is no formal education as such for this particular issue. We watch our seniors, we watch our colleagues and learn from them. If this part can be formalized a little bit also from the societies, from the associations, or from individuals.
Yeah, I would like Ashok to convert this into small research projects where I would like to go around a certain number of hospitals, smaller places, and try to actually share this experience because whatever we talk about is true, but if it is presented in real time, in real life, then it becomes much more, it's appreciated more. Um, so maybe we can apply some technology, some research to these topics. I mean, how to improve the patient experience in an outpatient.
So mute.
Not only of outpatient, but also in not only of the patient, but also of the relatives and the attendees of the patients. Even that becomes an important aspect because they also play a very important role in building an image for a doctor or a surgeon or a hospital in the community.
I mean, just to recount something. In most of the places where I have gone as an outpatient, I have found that the signages are very poor. And almost every time I have gone, I, as a doctor who is extremely comfortable in hospitals because I spent all my life in hospitals, I get confused because the whole signages are so wrong, so inaccurate that you get frustrated. So, I mean, I'm just giving you one example, which normally no hospital would even be willing to accept that they are in any way not good. But that's what I have seen. I mean, so of course things could get better. That's what I mean. I'm not saying hospitals or doctors deliberately do things badly. It's just that they don't give enough importance to these things as much as they should. That's all.
Most of them don't know that these things are so important.
Yes, but I think that they don't know because we don't teach them. It's the failure of our education. Why did they know? Because we think teaching them anything about practice is something that is business. It's not knowledge. It's not academics. So we will spend a lot of time teaching them about diseases and treatments, but we hardly spend any time telling them about how to deal with patients. And all this that we are talking in the last, since we started this musings, we are focusing on things which invariably turn out to be a failure or a lacuna in education. Maybe they're there in the syllabus, maybe they're not there, or maybe they're not taught. I don't know which of them, but it is what we are discovering as we are using.
Yes, absolutely. So one step at a time, gradually we are trying to make the regulating bodies listen to us.
And when I look at specific musings, I find that the amount of research or literature also gets narrower, also becomes more, because even our attitude towards research, in my humble opinion, as I keep looking at these topics and looking at the literature, I find that most researchers do not consider this worth thinking about also. How many orthopedic researchers are interested in working on improving the outpatient experience of patients? They would laugh, if you suggested this as a topic. They would get offended, They would get, annoyed. They would say, "Is this why you? What do you think of me? I want to invent a new nail. I want to have a new method of treatment, and so on." What is this? This is not research.
Right.
I'm just speaking for Ashok now.
Yeah, that's right.
Okay.
Right. Bye.
Yeah, we call it off tonight then.
Yes.
Okay. Wrap it up.